Right, the recording is on.
Okay. Dr. Van Dragen, thank you so much for inviting me to speak to your class about how we use EEG trending and for clinical applications. It's something we use pretty much on a daily basis here. And so forgive me, I don't know everybody's background about how much they know or have uh, reviewed EEGs or how much background they have about epilepsy, but so feel free to, ask any questions as we go. So this is a example of what a typical amplitude integrated EEG display looks like. And I guess I'll say we use this most often in neonatal EEG. It's very helpful. It's a very helpful tool for looking at trends and also identifying seizures. And it's mainly used in neonates and not too much outside of the NICU because we have better more helpful trends for older patients. But it's been used for a very long time, I think going all the way back to like the 60s for monitoring cerebral function in neonates. And so what you can see here is we have two channels, and each channel is made up of a pair of two electrodes. And some displays can even be single channel. And we typically like to use C3 and C4, P3 and P4, because those are placed over the Rolandic cortex of the baby. So that's the, the sensory motor area. And that's where most of the action is in a newborn, both physiologic and pathologic. And here is the amplitude on the x-axis, and it's semi-logarithmic. So it's 0 to 10, and then 10 to 100 microvolts. And that's really because most of the activity we're interested in is lower in amplitude, less than 30 microvolts. And we care a lot about suppression in neonates. And then here's time on the y-axis. So you can see this is compressed from about 6:45 in the morning to about 10:30-ish. So here I have a typical amplitude integrated EEG for a newborn who was 40 weeks and 4 days, and she's 3 days old. And so everything we review in pediatric neurology depends on how old the patient is, and in neonates, the gestational age factors into the what we call the post-conceptional age and tells us what we should expect as normal on the EEG. So this was a baby who had a hypoxic ischemic injury at birth. And so the baby had been placed on a cooling protocol to help protect it from secondary injury from the hypoxia. And so we're 3 days out, and here's where the amplitude integrated EEG really comes in handy. It can be a good prognostic tool for looking at sleep-wake cycling. And if you see nice sleep-wake cycles in a newborn with a hypoxic injury, that means there's a good prognosis. So we can see here, there's this pattern where we have epochs of a bigger range of amplitude, so ranging all the way up to about 20 microvolts and down to 2 microvolts. And then there are epochs of a more compressed amplitude between 5 and 10, but the baseline becomes higher. And so what we're seeing is this newborn sleep-wake cycles. So here's the raw EEG that corresponds to this point in time. And this is a discontinuous pattern that we can see in full-term newborns during sleep. So you see areas of bursts here and here, interspersed by lower amplitude slowing. And so this looks a little bit more like a trace discontinu pattern that we see in younger newborns. It's a little bit flatter here than we'd like to see in a healthy full-term newborn, but it's not terrible. And then here at a later point in time in the morning, we can see that the baby is awake and has a continuous background, and the baseline of the amplitude integrated EEG is well above 5 microvolts. And the peak is here in the teens. And then on the raw EEG, you can see a nice continuous background without the bursts and attenuation. Let's see. looks like.
I just also put a chat message. I should have reminded people that the first part of your talk on EEG is actually applying a moving average to the EEG, just such as people often do when they look at their stocks, as a matter of fact, or the coronavirus.
All right. So here's another example of the amplitude integrated EEG in a neonate. This is a 4-month-old X22 weeker. So if you recall, that 40 weeks is term, this infant was born about halfway through their gestation. So when I was in training, which wasn't that long ago, 22 weeks was really at the limits of viability, but we're starting to see more and more neonates that are resuscitated and survive. So 4 months later, the baby is now 40 weeks post-conceptional age, and you can see a similar pattern of sleep-wake cycles, but they look a little bit short with some lower amplitudes in the sleep baseline, so not as nice as our last infant. And the bursts are a little bit asynchronous between the left hemisphere and the right hemisphere. Here you can see the burst coming in on the right before the left, and the attenuations are a bit flatter than we saw in the last patient. So this, just the overall quality of the sleep-wake cycles is not as good, and it's much easier to see this at a glance on the amplitude integrated EEG than trying to compare the raw EEG, and I'll go back to that first one just to kind of compare. And so here, this is the same newborn, and this is the next portion of the EEG during wakefulness, where you do see a continuous background, and here we have some motion artifact as well. So in addition to just assessing the background and the overall quality of the sleep-wake cycling, it's very helpful in picking up newborn seizures. It doesn't pick up everything. Very short seizures or low amplitude or focal seizures can get missed. You know, if you recall, we're typically using 2 to 4 electrodes, and if your electrodes don't happen to be over the seizure, you'll miss it. And so here we can see on the raw EEG, this is a 40-weeker having a seizure, and the seizure probably starts somewhere out here because this big burst here is motion artifact, and so clinically the seizure is starting here, and we can see this is followed by attenuation in all channels, and then a buildup of rhythmicity here in the left frontal channel. So that's that FP1 channel here, and C3 and T3. And then here on the amplitude integrated EEG, we've got a time range from 6 in the morning to about 12:30. And what you see is that the baseline, if you're looking at that first, is pretty low. It's under 5 microvolts. So it's mainly below 5 microvolts, and you're having bursts of activity above that. And what you don't see here that we saw in the other 2 EEGs was nice sleep-wake cycling. So this is overall a suppressed EEG with lots of bursts in it. And then these little white divots or spikes here that we see mostly on the right side are the seizures. And I've been told that it kind of looks like someone's taking a stick and lifting up a stage curtain, if that's a helpful way to remember it. So that's a quick way to pick up on seizures. And so in newborns, one of our goals is to just quantify the seizures, and it's much easier to quickly count the seizures here and confirm that they're seizures than to go through the raw EEG. It's much easier to miss them because they often, you know, they'll be back to back or lead into each other, and sometimes it's difficult to find the onset and the offset. So this is a really helpful tool. So outside the NICU, we tend to use other types of quantitative EEG, like the CSA or the CDSA, the compressed spectral array, or the color density spectral array. And so I was reading that in studies, it takes the average EEG reader, if they're reviewing a 6-hour study and they're reviewing at a speed of 5 pages per second, it takes 20 minutes to read 6 hours of EEG. And that's if you don't do anything else, if you don't pause to look at things. And so a 24-hour EEG can be quite time consuming. And so using the compressed spectral array to help you hone in on areas of interest in the EEG is really helpful. So this is a little boy who came in for monitoring of his seizures. And here on the compressed spectral array, we can jump to different states, both sleep and wake, really quickly if we want to get an assessment of the background. So here's an example of the wake raw EEG. And he's got a pretty nice looking background with alpha activity, particularly in the posterior area. And we can hone in on that because here on the compressed spectral array, we have, it's actually frequency over time, and then color is the power of that frequency. So you can see here in the alpha range, that 8 to 13 hertz range, lots of increased power. So this is a good chance here that you'll find the wake alpha background. And later on, after he falls asleep, you can see the dropout of the alpha and a much more uniform background on the CSA. Here's the sleep structures with the K complex and the sleep spindles. All right, so this was a CSA on a routine EEG, and so we don't use it that much on the short EEGs just because it doesn't take that long to go through the raw data, but it does provide some interesting insights. So this was a child, an 8-year-old, getting a routine EEG for a first seizure-like episode. And I just posted this screenshot here. This is during photic stimulation at 4 hertz. So these red tick lines are the strobe light going off 4 times per second. And this shows the reaction of the occipital rhythms to the photic stimulation. So this child has very prominent photic driving, which could possibly be related to their underlying diagnosis. It's a little bit atypical. And then what we see here on the CSA is an awake background. You have a fair amount of activity in the alpha range when there's eye closure, and then these big kind of flame-like bursts of activity at all frequencies. The white is showing higher power, and so you can see a lot of higher power in the lower frequencies, but there's also lots of fast activity. So if we jump, if we were to click on this, it would take us to the raw EEG, and so sure enough, this patient had an absence seizure, and while she was resting with her eyes closed. So this is a typical 3 hertz spike and slow wave pattern that we see for absence, and this is just the CSA blown up. So it is helpful to, even on a routine EEG, to zoom out and look at the CSA and count the absence seizures and make sure you don't miss anything. Let's see, and this is just an example of what the CSA looks like in suppression. So this is a 14-year-old with a drug overdose, and you can see in the background, it's low amplitude. There's a fair amount of faster beta activity, a lot of 60 hertz artifact in the background of this one. There's also some slowing. So this is kind of an encephalopathic background that you might see in a drug overdose, because many drugs actually enhance the beta activity. And you can see on the CSA, there's not a whole lot of power above 5 microvolts. And then these are movement artifact here, these bursts in the higher frequencies. It would be pretty atypical to see physiologic activity just out of nowhere up above 20 microvolts, or yeah, above 20 microvolts. And then we have even fancier tools now. We have there's lots of different proprietary software out there for quantitative EEG or EEG trending, and one of the most popular ones is this PERSIST software. And it's a really helpful tool for monitoring for seizures, for monitoring for background changes like cerebral ischemia, and for bedside seizure detection. So it's helpful not just to the neurophysiologist or the epileptologist, but it's something that they've even studied, the bedside neuro-ICU nurse can use this to detect seizures. So in this example, this is one of our patients who had an epileptic encephalopathy and was in, had a really suppressed background in frequent seizures. And again, you can use this is the FFT, so the fast Fourier transform spectrogram, or the CSA, and you can quickly pick out here where the seizures are. But it'll also tell you the seizure probability and tell you if it thinks it's actually detected a seizure. So you could come along and count these as well. You can see that here's a seizure that's pretty consistent on the CSA, but it didn't reach the threshold. So it's not perfectly sensitive or specific. There are a couple other tools that Persist is helpful with. It has spike detections. So if you want to see if there's a dominant spike focus because you're considering a patient for surgery, that can be helpful. There are certain epileptic conditions where the goal is actually to treat spikes. So a syndrome called continuous spike and wave in sleep, or Landau-Kleffner syndrome, where you want to see if your treatment's working, if there are a reduced number of spikes, and it's much easier to have, software count those spikes for you than to go in and hand count them. And I'll just go back to this one. There's another trend that we look at is the suppression ratio. So this looks at the percentage of time in an EEG epoch where the amplitude is less than 5 microvolts, and that can be helpful for trending burst suppression or monitoring for early signs of ischemia. So those are my slides. I'll stop there because I know we're running low on time, for me at least. Any questions?
So in this graph of the suppression ratio, there's no point at which there's silencing. Is that right?
Right. So in this patient, I'm not sure why there's no trend for the suppression ratio. This is, I think, an error. Maybe it wasn't set up to trend that. But what you would normally see is you want to see a nice low line that there's no suppression or very small suppression. And you would, and it'll show you the right hemisphere versus the left hemisphere. So you'll have a blue line for the left and a red line for the right. And if you start to see that line trend up, then that can be an early warning sign for ischemia or herniation.
Thanks.
Yeah.
Kind of a general question about, like, because you talked a lot about like the NICU and the babies. Do you know, just curious, like, do they do EEGs on only the babies that exhibit signs of seizures, or is it like a routine thing that they do?
Yeah, so it's a good question. We don't EEG every baby that comes through the NICU, but any baby with any kind of funny movement or episode usually gets an EEG. So even if it's not motor activity, if the baby's having apnea, that's often an indication for an EEG. And then any baby who had neonatal encephalopathy, so if there was any kind of difficulty at delivery or they required resuscitation at birth, and their neurological exam's not normal, they go on EEG.
Okay, thank you.
You're welcome.
Well, considering the time, I know you are kind of in a hurry to kind of go to the patients, so I would say that you definitely deserve an applause. Thank you very, very much for your contribution.
Oh, thanks for having me. Happy to come back anytime.
Okay, well, we will take you up on that one, and I would thank you again, and then we'll just continue with the rest of the video on this. But I think this was an excellent example of how you can use all these tools in a daily setting.
All right. Bye, everyone.
Thanks, Dr. Ham.
Hi, thank you.
Thank you. Bye.